This Week in Microbiology is brought to you by the American Society for Microbiology at microbeworld.org/TWiM. This Week in Microbiology, episode number 22, recorded December 2nd, 2011. Hi, everybody. I'm Vincent Racaniello, and this is TWiM, the podcast that explores unseen life on Earth. Joining me today from the Medical University of South Carolina, Michael Schmidt.
Hello, Vincent. We're up to episode 22.
Yeah, pretty good. We're coming up on 1 year.
Yeah, we are.
We started, I think, in January of this year. So we're going along. We missed you last time, Michael.
I listened to it, and it sounded like you and Elio had a great time between the two of you. Again, poor Joe was having, I guess, technical difficulties or wasn't able to join you.
Yeah, she was in a meeting that ran over. So I said, it's okay. I don't mind one-on-one when we have to do that. It's fine. I mean, we have good conversations no matter what. Today we do have a third person, a special guest, someone who we had on TWiV a long time ago, TWiV 132. He's the Chief of Emergency Services at Our Lady of Lourdes Medical Center in Camden, New Jersey, Dr. Alfred Sacchetti. Welcome to TWiM.
Thank you very much, Vincent. I tell you, I had a great time on TWiV, and listening to you and Michael over this last year has been absolutely delightful.
Great. Yeah, we got a lot of feedback on your TWiV episode. A lot of people said they love to have the real-life stuff as opposed to the other stuff that we talk about, I suppose. So we thought since we started a podcast about microbes, we'd have you back and talk on this. So I'm really happy that you could join us again.
It's my pleasure. My pleasure. I wouldn't discount what you do since all we do is piggyback on what you guys do. So,
well, we can pat each other on the back, but I think it's, you're the real life stuff. You save lives. So, and,
actually, you bring up a good point because people always say, geez, you work in the emergency department, you save lives. But if you look at the most I can impact in any given year is about 5,000-6,000 people. And if you look at those 5,000-6,000 people, you could pull me out and put in any other emergency physician, and the care would be identical for almost all of them. There may be one or two where I might have sniffed out a diagnosis that somebody might have missed, but by the same token, there's probably one or two or more that somebody else would have sniffed out a diagnosis that I missed. So the most, even in going back over my entire career, it's maybe 160, 180,000 people. What you can do, what you did actually with just your work with the polio, and Michael, I apologize, I'm not familiar with what your area of expertise in microbiology is, but you've saved millions of people in just, so you look at it and you say, well, yeah, I can see a more immediate response to something I do if I put a pacemaker in somebody or something, but in the overall scheme of things, at the end of the day, you and Michael have impacted millions of lives compared to 100,000 or so.
Well, when Michael's work comes out, he's going to be the impactor, I think.
Yeah, I'm working on the control of hospital-associated infections. We're trying to go after the fourth leading cause of death in the United States to try to lower that scary rate where you probably know that if you walk into a U.S. hospital, our statistic is you have a 1 in 20 chance of acquiring a hospital-associated infection. And, the Canadians are a little bit worse than us. They're about 1 in 8. And over in Europe, depending on which country you look at in Europe, it can be 1 in 8, 1 in 12, 1 in 20. And so it is a pretty frightening statistic. And if you get admitted to the intensive care unit, it's even more frightening, where the rates in the United States are about 27%. So it truly is frightening.
Absolutely. I saw your initial stuff on the copper, which I thought was fascinating. The one thing that came to mind when I saw your stuff, I thought, you know what? I wonder if in the United States, the waterborne rate of infections is so low is because so many homes have copper tubing.
There's a lot to be said about putting copper plumbing in. And, if the NIH had, dollars available to do what-if research, we probably can do a retrospective study now that a lot of municipalities are putting in plastic piping. And we know that they have to increase the concentration of chlorine in order to chlorinate the water because, of course, it leaches out of the plastic, whereas the copper-piped water remains potable with less chlorine. So it's a rather interesting observation that the water microbiologists have tumbled to as municipalities have gone to plastic plumbing and as more and more homes are being plumbed with plastic. So it is really a fascinating area. And as you well know, being in the front lines of the emergency room, diarrheal disease is, of course, a big thing for children. And many of those diseases are, of course, easily transmitted via water and other ways.
Oh, absolutely. That I got news for you. We're switching all our cribs in the ER over to copper. That's it. You convinced me. Look, they'll be more durable. I can guarantee you, every kid we stick in the crib at some time or another starts gnawing on the bars. So,
wow.
If we made them out of copper, I think we would cut down on transmission significantly. I have to tell you though, you look worldwide, number 2 cause of death for people under 5 years of age is diarrhea. So it's nothing to laugh at. In the United States, it's an inconvenience, but worldwide, it's terrifying.
Well, this is why copper is in old observation. It's one of those empiric observations that humans made millennia ago, because they appreciated that if you put water in a copper vessel, that it would be potable by the time you needed to drink it at dinner. And so what they would do is they would go to the well or the river and collect the water, put it in a copper vessel, and it would become potable, because you didn't have to understand the germ theory of disease to understand diarrhea, because humans truly understand diarrhea when they see it.
Now, does that apply to bronze as well?
Yeah, bronze is, of course, copper with tin. And the concentration of copper that is antimicrobial is it's got to be greater than 60% copper by weight in the alloy. And so the Phoenicians figured out that when they sharpened their bronze swords into their wounds, the shavings would prevent the gangrenous attack. And so they could save the limb.
Which raises the whole issue when, if you go back, and I'm no historian, but you see the rise of the communities that had bronze technology a little bit quicker, and you wonder if they just had less infectious disease.
This is one of the wonders of the whole area of microbiology, as you begin to think about the rise of civilizations and why certain cities that were next to rivers that had a significant flow to effectively dilute the sewage and the associated diarrheal diseases. I mean, sanitation is perhaps the principal reason that infectious diseases have waned in the 20th century. As we began to deal with our waste in a very effective manner. And of course, Vincent worked on the aspect or the consequence of sanitation, and that was the rise of polio, because it, of course, is a disease of civilization. Because as we got better dealing with our sewage and waste, polio was able to establish a foothold.
It's a very interesting story. Yeah, it's one of these things you make it better, and the infection gets worse.
Yeah, we were taught, and Vincent, correct me, that polio really never really arose until you got to a point where people were contracting it at a later age. So if you were a medieval child playing in the mud, you contracted it when you were an infant, and it left no neurologic or minimal neurologic deficits. But then when you got it when you were 5 or 6 is when you got the profound neurologic deficits.
So the story is that epidemic polio did not exist until, as Michael said, we improved our sanitation, because then you delayed infection. So in most pre-sanitary ages, everyone was infected close to birth. And when we delayed it, we had collections of susceptible people in cities or urban centers, and then you introduce the virus into them, and boom, you have an epidemic. It's also true that at a young age, there are more inapparent infections, and the paralysis is less severe. When you start infecting kids, in near 10 years of age, then you have the paralysis, which is what we see in epidemic polio. Which is not to say that infants infected with polio don't get paralysis. They do. It's just less frequent than if you get infected as an adolescent. It's a very interesting story in itself. Now, Al, you said that you see about 5,000 patients a year in your emergency room. Is that right?
No, that's me personally. I see between 5 and 6 personally. The emergency department sees this year we'll see about 60,000.
So is that a medium-sized emergency room or a big one?
We are medium to large. The ERs kind of break down kind of funny. They break into these giant university-type centers where you're going to see about 100,000 visits. Mm-hmm. And then you get into the large community emergency departments where you're between 50 and 60. And then you drop down to relatively small places. It'll see about 20,000. And they tend to be rural, a little bit more isolated. So we're in what would be termed an urban teaching community hospital. So we're in a city. We're in Camden, New Jersey, which is right over the river from Philadelphia. And we pretty much split the city into 3 different emergency departments. The actual true university emergency departments across town, they see about 65,000. We see about 58, 60. And then there's a smaller community emergency department that sees about 30,000 in the city itself. So that's how we split the population up. And that's pretty much what you would see. Now, New York's a little unique, Vincent. They have, for the most part, so many large medical centers, and they all see well over 100,000 visits a year. Mm-hmm. So, but the interesting thing is when you look at them and you break the actual visits down, they all pretty much break down about the same percentage that are chest pain, same percentage that would be infectious, same percentage that are traumatic related, excluding the trauma centers, obviously, that see a little bit more. But I took a look at this actually because when we talked on TWiM, we said about 12% of all the visits we saw were viral related. Mm-hmm. So I went back and I went through what we have so far this year, which is up through October. I've got the database on that, and went through and picked out just back of the envelope, real quick calculations, and got about 15% of all our cases were bacterial related. Mm-hmm. So microbiology plays a very, very big part for us. And the big difference between viral and bacterial, and there's obviously overlap because some things such as bronchitis, I can't tell you whether it's a virus or a bacteria. But the big difference is where we talked about viruses, when you get your symptoms, pretty much your viremia is beginning to wane and you're getting better. When you get the bacterial infections, you're kind of on the upswing, and we really can make a difference. When we give antivirals, we're kind of chasing our tail because the virus is already going down. But on bacterial infections, you give antibiotics, antimicrobials in particular, you are definitely impacting the course of the disease. So it does make a difference there.
So Al, what I'm going to preface this. My former student is an ER attending here at my institution, the Medical University of South Carolina. So I pimped him today and asked him, I said, what's the number one infection that he sees? And I didn't preface it as to whether it was viral or bacterial. Mm-hmm. And he sung out a chorus of Mrsa, Mrsa, Mrsa. Is that what you're seeing?
In fact, I knew we would be discussing that, so I actually have some really good data on that from our place. And as a matter of fact, he is absolutely correct. Actually, the number one for us, and this is just for this year, I looked at it, is actually urinary tract infection across the board.
Yeah, he said UTIs. Yep. He's actually going to become the chief of the pediatric ED. And so he was very much concerned about UTIs. And what really surprised me is he said UTIs are quite common in children.
Yes, about 7 to 8% of all children with a fever without a source will turn out to have a urinary tract infection, which actually kind of gets interesting. I just did this lecture for the American College of Emergency Physicians back in October, so I got all the statistics. But here's the problem. If you look at children who have fever without a source. Now, fever without a source is defined as when you look at the child, they don't have an obvious source of infection. They don't have a runny nose. They don't have a viral upper respiratory infection. You don't see a source on them. And now you got to start hunting for it. Back in the 80s, actually 70s and 80s, you were looking for bacteria like Haemophilus influenza, Strep pneumoniae, Neisseria, and these were incredibly deadly bacteria. The kids who got Haemophilus influenza, a significant percentage of them would go on to get a bacteremia, meningitis, and a lot of them would just get septic shock and die. So they came along with the vaccines that cleaned up Haemophilus influenza. Then the bad bug was Strep pneumoniae, and they've cleaned that up now. So now
they had another vaccine. They had another vaccine. And again, this is where I get on my soapbox and say, one of the most important things parents can do is to listen to their pediatricians and vaccinate their children, because it will cut down those frightening visits to the ED.
Yeah, Vincent knows my stand on this. I went on a 20-minute rant last time I was on TWiM about the stupidity of not getting a vaccine. It's if we have time, we'll touch on it. But the reality of it is, I tell the residents when we teach them, I said, back in the day, it was once a month I would put a needle in some little kid's back to do a spinal tap and just get pus out, and it was just frightening because you would literally have to tell that parent, listen, your child's never going to be the same about this. Nowadays, number one, the age of meningitis is now 22, and it's all the college kids who get Neisseria. You just don't see bacterial meningitis in children anymore because of that. It's just cleaned up so nicely. So now the only bacteria that we really see is urinary tract infections in these kids. And it's fascinating when you look at the epidemiology of it, because when you look at urinary tract infections and you say, well, who gets them? Well, this is the population that gets them. It's interesting. Females, obviously, because the anatomy is such that the urethra is smaller and they'll get urinary tract infections. Uncircumcised males under 2 years of age tend to get it. But it's interesting that Caucasians are much more susceptible to urinary tract infections than any of the other ethnic groups.
Really?
No one is sure why.
Do you think it has to do with the genetics of the epithelial layer enabling E. coli and Proteus to attach its pili more easily?
That's the theory. The theory is that there is something different in the epithelium of the bladder in the Caucasians as opposed to the darker skinned races. And it's the exact antithesis, because in the United States, a lot of the people, the poorer population, the lower socioeconomic groups, tend to have more of a predilection towards the I guess the African American and the Hispanic populations. It's the nature of society in America, and usually the lower socioeconomic groups are more susceptible to the diseases, and we see it in terms of pneumonias and those kind of things. But this is one disease where the genetics is such that even though they have they don't have as much access to medical care, they tended to not get this disease. And it's clearly got to be a genetic issue somewhere along the line.
That's absolutely fascinating because, as you begin to – we've been dabbling a little bit in our discussions over the last few months over the microbiome, almost to the point where I think Elio's ready to have Vincent and I killed. But I think this is another instance where the microbiome is not a good player, but UTIs can manifest themselves for a wide variety of reasons, from simple dehydration, allowing the bacteria to effectively establish a better foothold, to just being present. And with this. There's no substitute for good shoe leather epidemiology, and what you have just given me is a great piece of shoe leather epidemiology that I didn't really appreciate up until this point in time. I knew about UTIs in women. I knew about UTIs in elderly men due to the prostate insufficiencies, and I knew about the little kids, especially the uncircumcised 2-year-olds, but I didn't know about the Caucasians.
Yeah. It's Kate Scholl did a lot of this work out of Children's Hospital of Philadelphia, and actually, if you talk to your buddy, he'll be able to give you that as well. And it is an interesting thing, because as much as possible, you need to when you approach any patient, you got to take in all the aspects of their care, and it's usually rare that we take race into account when we're looking for specific diseases. High blood pressure is obviously more common among the African-American population. You can get some differences in terms of multiple sclerosis. Those kind of diseases are more common in fair-skinned individuals. But when you see something like urinary tract infection, so when we see an infant with a fever without a source, you begin to think, okay, your odds are a little bit different. And it's not even just a little bit different. It's dramatically different between the two populations. So the light skin and the dark skin. And it always follows that classic pattern. It's almost like a migration up from the equator. That seems to be it. As you lose your pigmentation, you get more susceptible to certain diseases. So it is kind of fascinating when you start to look at that.
So Al, when you say 7 to 8% of urinary tract, is that the number 7 to 8%?
Yes.
That's in children.
In children is bacterial, is that right?
Correct. 7 to 8% of children in what's called a fever without a source. So
okay.
Mom brings Twinkie in and she puts her on the crib and she says they've got she's had a fever for a couple of days. You look at them, you can't find anything.
Okay. So then what do? You take blood and urine? Is that typically what's next?
You have to get the urine from them. So you have to catheterize them. Which is not always a fun thing to do with these little kids. You can screen them with a urinalysis. So if you can get the kid to urinate into a bag, it's a little easier with a guy. They put these little bags on them.
Yeah.
Girls, it doesn't work that well. So really, what you wind up doing is you have to catheterize them because what's important, Vincent, is you got to get the culture out of them. You can't just look at in an older person who can cooperate and clean themselves properly and give what they call a midstream clean catch urine. They start to urinate and then they catch it halfway through. You can get a urinalysis and you can tell whether they have an infection or not. Where in the children, you actually have to culture it. So what you would do is you culture them, you get the specimen, you split it. Half goes to the lab and they will dipstick it. And what they do is when they dipstick it, they'll look for leukocyte esterase, which is they're looking for that specific enzyme that's made by white blood cells, which tells them there's white blood cells in the urine. Mm-hmm. They'll look for nitrites or nitrates, which are made by the bacteria as they metabolize the urea that's in the urine. And then what they'll do, and usually the dipstick also shows up whether there's some red blood cells, because usually if you have a bladder infection, you'll have some red blood cells in there. Mm-hmm. Then so that will give you a hint that there's a urinary tract infection. So then what you have to do is culture that, and then the culture tells you whether you just got contaminated because the child's got diarrhea on top of everything else, so there's white blood cells all over the place down in their perineum, and you're just looking at contamination, you actually have a urinary tract infection. But if you get a positive urinalysis where you see the white blood cells, you see the nitrates, you see the leukoesterase in there, you're going to start them on antibiotics presumptively until you get your culture back. And that takes about a day to get back on them.
Okay. Is it mostly E. coli?
Oh, E. coli, and E. coli. The other thing that's interesting is it's not a bladder infection. These kids actually have pyelonephritis. The infection's up in their kidneys.
Ah. Ooh, that's spooky because then you involve the immune system.
Yep, and the interesting thing is the big worry about them is that they go on to scar the kidneys and get hypertension, which is one of the arguments that a lot of children have unrecognized urinary tract infections and wind up going ahead to get scarring, and that's where you get the hypertension from, which is kind of interesting in and of itself. So it gets very, very kind of involved as you go along. What's fascinating is when you really look at it, it's in the past. The treatment, if you go back 10 years, the treatment of a child with a fever, you looked in their ear and you saw a little bit of a red ear. You said, oh, you must have an ear infection. I'm going to put you on some antibiotics. And the antibiotics that the child would typically go on would cover a urinary tract infection. So what they felt was a lot of these kids were inadvertently getting treated. Now what's happened is they've really gotten the pediatricians and the pediatric epidemiologists have gotten really aggressive in saying, you know what? This doesn't make a whole lot of sense. Why these kids are getting fevers from this red ear? And they've gone in and what they found is that most of these ear infections are actually caused by viruses. They're not caused by bacteria. So there's been a big switch away from treating the ear infections with antibiotics. And so now these children are not getting the antibiotics, which is forcing people to look a little more closely for where the real source of the fever is, and we're finding it in their urine.
Wow. That's amazing.
And this is big because if you begin to... in 20 years when we go back and begin to do the epidemiology on the hypertension associated with this, I'll bet you'll be able to pull out, as medical records are now getting a little bit better and they're more easily searchable, I'll bet you'll be able to pull out a fever of unknown origin at some point in the child's past. And if you begin to look at idiopathic hypertension, it could be a consequence of the pyelonephritis.
Yep.
And so this really, this really is going to drive the standard of care in terms of, thinking about the costs associated with the long-term costs associated with medicine. It really drives home the importance of, paying attention to what's going on with your body.
I think you're right there, but it also drives home two points that keep showing up is the more people look, the more you find there's an infectious disease cause kind of somewhere linking in just about everything. A lot of environmental stuff or things we believe are environmentally related. When you really start to look a little more carefully, you find that somewhere along the line there's some microorganism that's causing all this mischief. And I think one of the things that you look at that is, do people have these chronic smoldering infections which lead to just inflammation? The bacteria itself doesn't cause an abscess or the virus doesn't cause specific disease, but it just sets up this smoldering infectious or inflammatory process, which then leads to whatever the pathology that shows up long term. And I think you look at the viral hepatitis, they're bad, but it's this 20 years of this inflammatory process that ultimately leads to the cirrhosis that gives you all the problems and that goes along with those things.
Yeah, I think you're absolutely spot on with that. It's, it goes back to our good friend, Dr. Schechter, who asked in one of his famous Talmudic questions, can you name any disease that does not have a microbial component?
Yeah.
And you're hard-pressed to come up with one.
Yeah, I think we're for a while there it looked like even some of the cardiovascular diseases had a chlamydial component to it, which was kind of fascinating. But I do believe there is probably a bigger role to chronic inflammation than we've ever suspected before in what's going on there.
So Al, let me just ask you, when these kids have the culture that shows E. coli, then what do you do?
What'll happen is they'll presumptively get treated. So if mom brings the child in and we look at Twinkie and we say, you know what, she's got a urinary tract infection from the urinalysis. We see white blood cells. Okay. And on a straight cath, we catheterize them so there's no contamination. So what we see in there is we see some white blood cells. We see the leukoesterase is positive. We'll start that child presumptively on an antibiotic. And depending on how sick they look, they may get it intravenously and get admitted to the hospital. Most of the time, they'll get treated with an oral antibiotic and go home. So we'll put them on something like trimethoprim sulfa, which is Bactrim, or they may get even something as simple as cephalexin, a cephalosporin like Keflex. Mm-hmm. And then we'll follow the urine culture. The urine culture will come back with, it'll identify it as E. coli. We're looking for greater than 100,000 per bacteria. And it'll come back with the sensitivities. And what we'll look at the sensitivity, it'll tell you it is sensitive to the antibiotic we put them on, in which case then we'll just call them up and say, Mom, you got to keep them on it for 10 days. But at that point, we've also handed them back over to their primary care pediatrician.
Right.
Yeah, we're pretty bad at following things.
That's the one question I have to you, Al. Obviously, your hospital's antibiogram.
Yes.
But how well does the hospital's antibiogram reflect or is relevant to your patient demographic? Because oftentimes you don't culture your patients.
Correct.
So you're really not, or you're not going to order the sensitivities for your
Correct.
patients unless it's something like this UTI. So how reflective is the antibiogram of your hospital to your demographic that's walking in through your front door, all 100,000 plus of them?
Tell us what an antibiogram is, too.
The poor man's version, it's effectively a snapshot of the microorganisms that are infecting the patients in the hospital and what they're most likely sensitive and resistant to.
Okay.
It's based on the epidemiology of the patient population that's being admitted to your hospital, and the clinical laboratory routinely, when they culture, they routinely do sensitivities to determine the antibiogram, and it comes out at least on a quarterly basis, if not more frequently, if they're having issues.
Yep.
And our friends in the clinical laboratory do yeoman's work making certain that our attending physicians as well as our residents are well aware of the creatures that are running loose in our hospital, so that when you do empiric therapy, where you're making a clinical judgment to save that patient from any further suffering or damage, you can make a judgment call based on an empiric clinical presentation, and the drug that you're prescribing to them will have a greater likelihood of success. Now, some of these patients do indeed have multi-drug resistant and drug-resistant microbes, for which the antibiogram won't be accurate, and that's why they're constantly surveying the infections that come through the lab to determine, so they can give that physician the heads up that, okay, empirically this will likely work.
Right, and that's exactly on. But you bring up the good point, which is in the primary care setting, in the emergency department setting, a lot of times we're seeing people who aren't in the hospital. So it's a different population. And to go back to Vincent's question, this is kind of interesting. We will absolutely culture the urine on an infant and a small child who has a urinary tract infection. If that child's mother also says, you know what, while I'm here, I've been having this problem. I've been urinating a lot. It burns when I urinate. So she's 23, 24, however old she is. We would take her urinalysis and look at it. And it's supposed it comes back with the white blood cells and the same thing. We would not culture her. And the reason is because the data is so good on that demographic of people. So if you're a young female with a urinary tract infection, the data is overwhelming. It's going to be E. coli. And we would not culture that person. And the recommendation is not to culture them. And in fact, in the primary care setting, in the doctor's office, there's some ISDA, the Infectious Disease Society of America, even has some recommendations that say you can treat them first time, you can just treat them symptomatically. They come in and they say they have all the symptoms of a urinary tract infection, young female, sexually active, urgent, they're burning when they pass their urine, they're going all the time, the frequency, that type of stuff. You don't even need to look at them, just go ahead and treat them for 3 days. So we would not culture that individual. We would just say statistically, and we know from what's going around in the community. So the antibiogram not just is for the hospital, but we also have them for the community at large. A lot of the departments of health will filter that information down to you, or you can get it from the CDC. So what we'll get is information that says this individual, most people in this age group, they have a community-acquired urinary tract infection. They're going to be sensitive to Bactrim, the trimethoprim sulfa, Keflex, those types of medicines. We would treat that person once. The interesting thing is the concentration of the antibiotics is so high in the urine now that even if you take the urine and culture it and it says this bacteria is resistant to this antibiotic, the concentrations get so high in the urine that it still works. So we'll treat them for 3 days. That's all you treat them for anymore. We used to treat you for 10 days and it went down to 7 days. Now it's down to 3 days. And there is actually some regimens where you can treat them for 1 day. But the bottom line is we would treat you for 3 days and you should be better. If you're not better in 3 days, we'll see you back. Frequently, because where we're located in the city, a lot of these people don't have primary care docs. We'll just see them back in the emergency department. And at that point, we will culture you because now we know you've got something different than the average bear. You've got something a little bit more resistant. So those people we would culture.
Okay.
So it is age dependent how we manage you. Now, if you take that same individual who comes in from a nursing home who's got a fever and we don't find anything, and now we're back to catheterizing them. We catheterize them, looks like they have a urinary tract infection. Those people definitely need to get cultured because Lord knows what's growing in their urine. They grow out all kinds of resistant organisms.
They can have MRSA.
Yeah, absolutely. And we're back to your buddy's comment, which is, yes, we are seeing a ton of MRSA. So the next thing on the list, urinary tract infection was number 1. Number 2 was skin infections, cellulitis and abscesses.
Skin and soft tissue.
But
Yeah.
this is not fever of unknown origin, right?
No. Now we're back to just infectious disease diagnosis coming out of the.
So we're going to get back to fever of unknown origin because you only did 7 or 8%, right?
Right, exactly. 8% of them come out with
UTI.
A UTI.
Okay.
A smaller percent are going to have invasive bacterial infections. So you're down to about 1. Depending on the population you look at, you're down at most to 1%. Usually it's much higher it's much lower than 1% will have an invasive bacterial infection. So these will be people who would have, their urine will be clean, but if you cultured their blood, they would have a bacteremia, and you would be growing out. Most common thing you're going to grow out is going to be strep pneumoniae, and nowadays it's going to be either an unvaccinated child or it's going to be a child who's got a strain that's not covered by the current vaccination. So the vaccination covers, right now it's a heptaval, it's covering 7 of them. I think the new vaccine coming out soon will cover 13 of the serotypes of strep pneumonia. So that's going to be another 1%. And then the rest of them, you're going to have some oddball things. You'll see some things like salmonella will grow in their urine. You will see that small percentage that have Neisseria meningitidis, which is just a really, really bad bacteria that you just it just sneaks up on you, no matter how careful you look for that. This is one of those things where if you've got a child who's got Neisseria meningitidis, what's really scary about it is every blood test you do is perfectly normal in these kids. They have absolutely their white blood cell count is normal. Their differential's normal. Everything looks normal on them, and they're the ones who die within 24 hours. It's just a very scary disease, just absolutely terrifying disease. So you'll have a very, very tiny percentage of them. It's like 0.3% of them are going to show up in there, and the rest of them, it's a fever of unknown origin, and most of them are an unrecognized virus. It's funny. The first slide when I do this lecture, my first slide on the lecture is, okay, we're going to talk about fever. It's fever in children under 3 years of age is the title of the lecture, and the title slide is the fever in children under 3 years of age, and the next slide says it's a virus, go home. but yeah, it's the rest of them tend to be, and unfortunately, Vincent, viruses take a bad rap because when we can't find anything else, we just call it a virus.
And then you send them home and you don't do anything typically,
we
right?
Send them home and don't do anything. And guess what? They all get better. And like we talked about on TWiM, the number of the child in the family determines how many visits they make for the fever.
Sure. Al, what really has to be done, and somebody's got to do this, but probably doing already, take those kids and get a specimen of some kind and just sequence it.
But where do you get the specimen, Vincent?
Well, I don't know. That's the question. Because, there's so many possibilities, right?
Right. Well, I'll tell you what we do. For example, right now we were talking about, we are really in a real upswing of RSV, respiratory syncytial virus.
Mm-hmm.
We saw, and these kids aren't a fever without a source, because you could see they literally come in, their nose is running like a faucet and they're wheezing like crazy. They got they're very noisy breathing. So what we'll do with those kids is it's very easy and we don't need to know that. We clinically kind of suspect what they have. But if they're a certain age group where they're going to be admitted to the hospital, we want to know for sure, because when they go in the hospital, we want to cohort them with a bunch of other children that have the same disease. So what we do is just do we'll squirt some saline up their nose, put a suction catheter back, pull some material out, send it to the lab. They do an antigen test on it, and we know within 15 minutes that they have RSV.
Mm-hmm.
And it's the same thing. So those types of things aren't bad. So if you can sample something from a mucosal surface, it's going to be perfect.
Yeah.
But the question is going to be, and if we could do it with a drop of blood, it wouldn't be a problem. The problem rapidly becomes, if we're going to start sequencing, we need to start guessing what we're sequencing, because all the kids are colonized with hundreds of viruses at any given time. And it would be very interesting. Yeah. And this is one of the questions that's going forward is, how many, what exactly is going on in these kids that's replicating it. And we had talked about this before, and we will see this where we'll see, there's a baseline of children we're going to see coming into the emergency department. All of a sudden, we'll start to see a spike. And what we'll see is a big influx of children with these temperatures of 104, 105. And the first couple that come in, we get all worried. We draw a lot of blood work on them. We don't find anything. And we don't do the viral studies on them. We go, geez, we're not sure, but the kids look good. And then the spike will get bigger and bigger and bigger. And then all of a sudden it'll peak and then it'll go away. And we know it's got to be viral. The kids are doing tremendous. They do well. We watch them. Some get admitted. Most of them go home. But we know that's and it's not a recognized virus. Who knows what it is, whether it's a variant. But we see that every couple of years we'll see this type of thing come in. And I am absolutely convinced, Vincent, you're right. Somebody somewhere along the line is going to start to look a little bit more carefully. And maybe it's just a matter of getting a unique snippet of nucleotides that is unique to every given virus. Maybe there's, to the coronavirus all have this genetically conserved snippet of RNA that's not in any other virus. And maybe the herpes viruses have it that's not in any virus. So now you have a couple of markers, and then you could start screening the kids looking at those markers.
Sure. Yeah, you have to do initial studies and see exactly what's in them and then refine your probes based on that. But I do think, the easiest thing is to get some kind of a nasal wash or a sputum and start. And if you get that on everyone, then you could start with that. But then it sounds like you also get urines and maybe even, you don't get blood usually, right?
It's hard to play capture the flag with blood.
Yeah.
Because you sort of, the virus being much small, 3 orders of magnitude typically smaller than a bacterium. For these eukaryotic viruses, you're really trying to play capture the flag, and you'd almost have to drain the kid in order to get the PCR to work.
Yeah, if they had a lot of viremia, they would be really sick, I would suppose. Right?
But and you bring up a good point, because we do blood cultures on the really sick children.
Yeah.
We do a lot of blood cultures, most of which are turning out to be, we actually, we're not unusual in this. So we have more contaminants than we have true positives in the blood cultures.
Okay.
And that seems to be, if you look across the board, when we looked at the pediatric blood cultures, the articles written on them that I reviewed for the lecture, all of them had the number one bacteria grown was a contaminant. So what's really sad, Vincent, is what will happen is the most common thing you're going to grow out is gram-positive cocci. And that's now you're worried, oh my God, does this kid have strep? Well, as it turns out, strep pneumonia, most of the kids would clear on their own. So they get a bacteremia. It was very common where you would draw these cultures on the children. It will grow out the bacteria, and you go back and you look at the kid and repeat the blood cultures, and the child has cleared them on their own. So they did actually about 90+% of the strep pneumonia was cleared spontaneously. Haemophilus influenza and Neisseria aren't cleared, and that's why they do so poorly. So you would wind up, you drew a blood culture on a child. The child looked good. Their labs didn't look bad. You sent them home. The next day, the lab will call and say, we're growing gram-positive cocci, because the most common contaminant is going to be staph, which is a gram-positive cocci. So now you got to call mom up and say, Mom, your kid has a bacteria growing in their blood. Bring them back to the hospital. Mom says, okay, I'll get them off the swing set and bring them back.
It's pretty remarkable how quickly they come back. But I think one of the most intriguing things you said is at any moment in time, the young child is colonized with hundreds of viruses. And so when you have this fever of unknown origin caused by an unknown virus, is this our immune system just effectively developing its immune repertoire against these viruses? You're developing the true correlates of immunity so that you can, go through life without getting bizarro virus number 4 again.
I think you hit the nail right on the head. It's just the immune system flexing its muscles. And I think we see that all the time. One of the things that I think is coming very clear now, and you guys have touched on it, is the more antiseptic you make a child's environment, the more pathology they get later in life. And that's becoming very true. What we're seeing is a number of diseases. We're seeing an increase. There's no question about it. We are seeing an increase in medicine, not so much emergency medicine, but medicine in general, of autoimmune diseases. We clearly are seeing this increase. And I think part of that is you've got this very aggressive immune system in people, and it's looking to fight something. It's belligerent. It's looking to fight something. And if you don't give it things to fight, it's going to start picking on itself. So things that if you have an immune system that's actively fighting a bacteria or a virus or a fungus or whatever, it's not going to be looking to start picking on the pancreas or the colon or anything else. And I think that in the last 2 years, some fascinating data has come out on Crohn's disease, which is an inflammatory bowel disease. It's a small intestine and large intestine both. It's an autoimmune disease where the body's immune system starts attacking the gut, and it's a pretty miserable disease. But what they found is if they took people with Crohn's disease and infected them with parasites, they gave them worms. You had to, I guess if you're sick enough, you drink a vial of worms. Their Crohn's disease symptoms went away.
Yeah.
And I think what you're seeing is, look at, I guess the classic virus is the infectious mononucleosis virus, the
Epstein-Barr.
Yeah, Epstein-Barr, where if you get Epstein-Barr before age 18, you generally do well. People who get Epstein-Barr after 18 have a much higher incidence of lymphoma. So you have to really step back and think about it. And I remember, look, I'm of the generation we got all the viral disease when we were children, but I had some younger siblings who didn't get their chickenpox until they were 18, 20, and they were miserable. They were miserable, is right. I mean, they were absolutely miserable. When my children got it, they got it when they were 2-3 years of age. Well, my son got it, gave it to his sister. He had gone to school. He came home, gave it to his sister who was even younger. She had like 7-8 pox, and that was it. So
what you were talking about with Crohn's is effectively the IgE hypothesis, that if your immune system is busy with its IgE response to the parasite, then it's not going to get busy with the autoimmune associated consequences associated with the Crohn's or some of these other things. And this is one of these great anecdotal pieces of data.
Yep.
And I had a technician who had asthma for all of her life. Mm-hmm. And she went with her husband to a meeting in Europe and ended up getting a parasitic disease while she was overseas. And she came back and she was cured of her asthma and still remains cured to this day.
Yeah, wow. It is. I think that the immune, and it's interesting because virology dovetails so well with immunology. And I think microbiology, because we have antibiotics to treat, we tend not to look at the immune system as carefully. But you look at that, I think more and more diseases is going to be, you're going to see exactly that kind of thing. If you can control the immune system, we're going to see a lot better control of a lot of these chronic diseases, asthma included.
Well, asthma, as you bring up, we had a TWiM episode where we discussed Helicobacter pylori,
right,
and its dilution from the technologically developed populations of the planet.
Yes. Yeah.
And so Helicobacter, if you have the virulent form that causes ulcers and cancer and potentially Parkinson's, if you have the virulent form in your gut when you're young, you will not develop atopic asthma.
Mm-hmm.
And, it's one of these remarkable observations. And, it's not as cut and dried as everyone would like it to be. There's good bugs and bad bugs. I think all bugs are important. And it's like everything else, everything in moderation. You don't want too much.
Yep.
Otherwise, you'll run into problems. And the trick is, we developed in a very diverse world. And as we begin to incorporate antimicrobial soaps and antimicrobial surfaces and, keeping that child inside more than keeping them outside where they're not exposed to the microbial world and the world, their immune system may not be learning important lessons that it really needs to stave off these autoimmune diseases that we often develop in our early 20s as our immune system says, okay, puberty's over, you're now an adult, let's see what else we can do to you.
Yeah. That's a very good point. And take it one step further. Are we evolving a subset of humans that do well in this antiseptic environment because their immune system is not, I guess, as hypervigilant as others, and then you take them out of that environment and move them somewhere else, and they're much more susceptible to the organisms. I think it's going to be fascinating to see how immunology plays out over the next couple of decades. Getting back to your buddy's comment about the Mrsa, you can't do emergency medicine now without talking about this bug. This is a fascinating organism. I guess, have you guys done I went through the TWiMs. I don't think we did. No. You did Mrsa. No.
We haven't.
We haven't done Mrsa yet, and I think it's one of those topic areas we really need to talk about because, Staphylococci, because they're such an important component of our normal flora, besides Staph aureus, there are other Staphylococci, the coagnegs and all the other subspecies and species associated with Staphylococci that inhabit our skin it's really one of these microbes that we've learned to coexist with, and our immune system really doesn't develop immunity to it. It's us.
Right.
And so it really is not going to be a simple problem to crack. And I think that's why we're beginning to see it in America that walks through your doors.
Over my career, I've seen various things wax and wane, but this is something that's very recent that I can really say, for the most part, I've watched medicine advance and see diseases go away. This is one where I really can remember the absolute onset of this entity and how it evolved into what the problem it is today. Now, I guess for people who aren't familiar, I guess there's Staph aureus, there's methicillin-sensitive Staph aureus, and methicillin is an antibiotic. There's hospital-acquired methicillin-resistant Staph aureus, and the methicillin-resistant Staph aureus is where you get the Mrsa from. It's Mrsa. So it's methicillin-resistant Staph aureus. And that is a very, very nasty bacteria because it's just resistant to so many antibiotics. It's not just the methicillin it's resistant to. And once a hospitalized patient gets this, and Michael, this is right up your alley. They're in a deep pickle there because this is a bacteria that's going to be hard to treat, and it is virulent at that time. What appeared, I guess, at least to my recollection, was probably about 10 years ago is when we first started seeing it, and we didn't know what it was. At least I didn't know what it was community-acquired Mrsa, community-acquired methicillin-resistant Staph aureus. And it's a very different organism from hospital-acquired Mrsa. Its antibiotic spectrum is different. And more importantly, hospital-acquired Mrsa behaved like regular Staph aureus. It gave you the same infections. It was just more difficult to treat. Community-acquired Mrsa, I'm convinced it's a different organism altogether. Everybody keeps calling it Staph aureus, but I think it picked up a whole bunch of new enzymes and new genes that made it not just resistant to the bacteria, but a much, much more aggressive organism. It's the infections it causes are much more deep-seated. It spreads much more. And I think people looked at, there's a couple enzymes that appeared in it that didn't appear in regular Staph aureus. But even if they take those enzymes out, they knock those enzymes out, it's still a much more aggressive bacteria. So what we saw, going back about 10 years ago, we saw some skin infections. And most skin abscesses and cellulitis are either staph or strep. They easily responded to antibiotics. And the abscesses, where you get that boil, that collection of pus, you would incise and drain it. You just kind of cut it open and drain the thing. And sometimes you pack it with some ionoform impregnated gauze. And these people all did well. Well, we began to see them, and they looked different from the get-go. And within about a year, we recognized this is a different organism. We didn't know what it was, but we just knew it was different. What you see is when you see a normal a methicillin-sensitive Staph aureus infection, what you would see is it's a bright pink cellulitis, and then the abscess is kind of water balloonish, like it's this little collection of pus. You open it up, it drains like a water balloon, and you're done with it. What we began to see was this very, very dark violaceous cellulitis. They were really almost like a purple color, and they were much more painful. And the infections tended to be, when you opened them up, they went much deeper, and they weren't just a single pocket. There were lots of little pockets and lots of digitations and septi that we were winding up having to break up. And they were also appearing in parts of the body where we never saw them before, where normally you get most of your staph infections are up in your armpits and your axilla, down in your groin, in these moist areas. And the drug abusers would get them where they shoot up. It was not a problem. We were seeing infections in the middle of the arm, in the middle of the leg, in children, which we had never seen before, and now we're seeing a lot of, is we see them right on their butts, on their gluteus, not around the anus where you expect to see like the perianal infections. These are way out on the gluteal areas. And we were seeing infants who were getting these infections that we never saw before. And so people started to track, start to culture them, and sure enough, they grew out, turned out to be community-acquired Mrsa. It's a very different, clinically, if I were to take you into the ER and show you a dozen abscesses, you would very quickly be able to tell just by looking a Mrsa abscess from a methicillin-sensitive Staph aureus abscess. They look different and they behave different.
And that's what Keith, my former student's name is Keith Borg, and
Sure.
that's what he told me. He said, you don't throw antibiotics at them. What you do is you put a knife to them, you cut them open, you dig them out, and you drain them, because that's much more effective than just throwing an antibiotic at it, where you give them a pill. You really got to drain it. And this is going back to old-time religion before we had antibiotics, because that's how you used to treat boils.
Yep. Yeah.
I remember when I was a young microbiologist sitting in a lecture listening to a story from an old-time physician describing how the poor used to take care of boils. They would take an old glass milk bottle and they would put it in a pot of boiling water and heat up the milk bottle. And then they would take the milk bottle out of the boiling water, cool the lip of the milk bottle, and then invert the milk bottle on top of the boil that was on the butt. And as the air cooled in the milk bottle, the boil would burst explosively, effectively doing the surgical debridement.
Yep. Yeah.
And at first I didn't believe it. And you would get all this pus inside this milk bottle. And then the grandma would rinse it out and pour it down the drain and put it out for the milkman to pick up and put milk in the next day.
There you go.
Wow.
But it's again one of these empiric observations that humans made, how to give themselves relief before they understood what they were doing, and it was really teaching them, the best practice of evidence-based medicine.
Yeah.
Hey, so Al, when you see this boil, you know it's MRSA. You don't have to do a culture.
Traditionally, to tell you the truth, Vincent, we culture as little as possible if it's clinically we know what it is. A couple of reasons. One is it gets pretty expensive for these people to do the cultures, and number two, by the time you get the results back, they're either better or they're not. So we go by the biograms. If the biograms for the community say this is what the sensitivity is of the most common ones we'll get, sensitivity of Neisseria gonorrhea in the area. So we don't necessarily have to culture it specifically to get culture and sensitivity. We may just culture for epidemiologic purposes to identify the organism. But the skin abscesses we never really used to culture because we knew it was staph or strep, and we knew it was sensitive to cephalexin, the Keflex. So we never really cultured them. When the Mrsa came along and things weren't getting better with the typical antibiotics, then all of a sudden we started to say something's amiss here. So we went back to culturing. Now we've come full circle. Infectious Disease Society of America, the American College of Emergency Physicians are all recommending now you don't need to culture them. It's Mrsa. And that's, if you culture them, when they do the periodically, they'll say, okay, we want you to culture a bunch of them so we can see what's going on. It all comes out Mrsa. Okay. I looked at, just looking at our data here from 2009 to 2011, what I looked at was, and this is about 160 some thousand visits. In 2009, 3.2% of our visits were either cellulitis or abscess. By 2011, this year, we're at 3.8%, and that's statistically significant, down to 0.001. So it's we're seeing it grow. Now, if you're thinking about, the guys went up about 0.5%. 0.5% out of 50,000 visits, 60,000 visits. That's a pretty big jump. You start to get up there. It's a couple thousand visits a year that we're seeing for this. And again, now we're back to not culturing them, and we just assume that they're all methicillin resistant. And there's a couple of antibiotics that surprisingly they have remained sensitive to. Now, the hospital-acquired Mrsa is not sensitive to things like Bactrim, and Bactrim is trimethoprim sulfa. And the community-acquired methicillin-sensitive Staph aureus is not sensitive to it. But it's the one antibiotic that this Mrsa, community-acquired Mrsa, has remained very sensitive to. And there's a couple other out there. They're still sensitive to vibramycin, and they have mixed sensitivity to things like rifampin and clindamycin, those types of antibiotics. But it is very, very fascinating. And I'm going to make a prediction, Michael, that somebody's along the line is going to say this isn't. They're going to call this a whole different species of staph because it just behaves so differently clinically than regular Staph aureus.
Well, I think this goes to the conundrum microbiologists are having these days, where we really got used to speciating things by 16S ribosomal RNA. And what the poor clinician has to deal with is the different behaviors. In the old days, we had salmonella, and there's a long list of different species of salmonella because each and every one of them had a specific clinical syndrome that was associated with them. But if you typed them today by 16S, they'd all be typhimurium. Right. And I think what we're really going to have to do to help the clinicians understand how to do this, in the trenches type medicine where they do have prudent use of antibiotics, is to really name them so they can really empirically figure out what the poor patient is presenting with and then give them the right treatment in order so that we do have antibiotics and we don't spread antibiotics around for which we really don't need them.
Absolutely.
And that's the danger the poor guys in the ED are facing is, your patient typically comes and goes very quickly, or they want to come to come and leave very quickly. Yeah. So you don't have the luxury of waiting for a culture or waiting for even a PCR test to come back.
Yep. And one of the issues, and medicine is, absolutely its worst enemy for this, is just the inappropriate use of antibiotics for diseases that don't need antibiotics. And that's why the big mantra now is just IND the abscess, don't put them on antibiotics, and we're not putting them on them now. Don't put the ear infections on antibiotics. It's probably not a bacterium. If they fail, a couple days of outpatient therapy without antibiotics, then consider it. All the infectious disease societies and the microbiologists are really pushing very hard. And at the same time, most of the clinicians, it's not as bad for us. We're emergency medicine is not as bad. But if someone says, I absolutely am convinced I need an antibiotic, and you say, no, you clearly have a viral illness, an antibiotic's not going to help. If they get mad and stomp out, that's okay. We're okay with that. If you're trying to run a family practice or a pediatric practice or an internal medicine practice, and people leave because they don't get antibiotics, your practice kind of shrinks a little. So you're under a little bit more pressure to maybe prescribe some antibiotics that are, if someone's got a clear-cut upper respiratory infection, they don't need antibiotics, but some people are just convinced that they're just not going to get better. And believe me, if they leave your office or your emergency department, it's not that they're going home and just sulking. They're going someplace else, and they will keep going someplace else until they finally get their antibiotics. Mm-hmm. So look at Mrsa is an example of it. Look at what's happened with Clostridia difficile. That evolved into a very aggressive organism now, and here's where it's gotten very scary. In the past, if you gave somebody antibiotics and they didn't need them, they probably did okay. Society took a hit, but the patient didn't really take a hit. Now what we're seeing is putting people on antibiotics, and not just these broad spectrum antibiotics, but narrow spectrum antibiotics, and they're getting overgrowth of Clostridia in their intestines, and they're winding up losing their colon, so they have colostomies for their lives. And and these are young people, not just the nursing home patients. So now you've gone from just a societal risk of using inappropriate antibiotics to an actual patient risk of using inappropriate antibiotics.
Yeah, it's pretty sobering there.
Yep.
So we've got urinary tract infections. We've got MRSA, boils. What else? What else have you got?
Let's see.
What else have you got?
Yeah. Let's see. Up in the top. What else is up in the top 10 is, well, believe it or not, high in the top 10 is toothaches, which is sometimes these people come in with these ugly periapical abscesses where the whole side of their face is swollen, and you go in and, again, same thing, get the thing drained. You go in, you find where the pocket of pus is, open it up and drain it, and they do well. But the reason it's up that high has nothing to do with those cases, because lumped in with the toothaches are all the people who show up on Sunday morning with the complaint that they just happen to fracture their tooth and they're in excruciating pain, and the dentist is closed. Yeah, those people tend to appear routinely and move from department to department. But yeah, they're up there, but they're not truly there. But we do see some ugly looking toothaches.
When you have a boil or an abscess in the mouth, what is it usually?
Anaerobes.
Anaerobes?
Yeah, it's
a mixed infection.
Mm-hmm. Yeah, mixed flora anaerobes. So you get in there and you have to you get them numbed up, and again, this is one of those things where we'll frequently see someone who's been seen by just you have to know emergency physicians are a little nuts, and we'll stick a needle or a scalpel in anything. But
you have no fear.
Yeah, no fear is right, and not much common sense either. But so we'll see a lot of these people come in who've been treated by the family doc on multiple rounds of antibiotics, and you go, once you get that abscess in there, the antibiotics aren't going to clear it. You got to drain it. So you get in there and you drain these things. So they can get pretty big if people just keep pushing the antibiotics. The other things that are up there is pneumonia. Pneumonia is always a big one. And again, you can't tell, even if you get down there and you get some sputum out of these people, whether it's bacterial or viral, or most commonly it's going to be bacterial on top of viral is a lot of things that we see. So there we'll treat them with, again, you're treating these people empirically. If they're sick enough, they stay in the hospital, and there's certain criteria that you would keep somebody in the hospital, and certain criteria where you can let them go home. And then there's certain antibiotics that clearly the Infectious Disease Society of America and the American Thoracic Society has recommendations on how you treat these. The most common bugs out there for us would be strep pneumonia and Mycoplasma pneumoniae are the two big bacteria that we see. And usually we'll have to cover them for the atypicals because we can't tell. It used to be told that, well, you could tell pneumococcus gives you a clear, on the x-ray, it gives you a clear pattern of a lobar infiltrate, this one area where the infection is, and the Mycoplasma gives you just kind of a bat wing spread appearance. You don't see that anymore. They overlap so much that you pretty much need to treat them for both. Unfortunately, there's a couple of antibiotics out there that will treat both of those things. Strep pharyngitis is still around, and that we know we have because we will culture. We don't actually culture them. We do an antigen test for that, and we will know that they have strep back there. And then rounding up the top 10 is the ever-present sexually transmitted diseases. It's amazing. I mean, there's tons of historical papers on who gave what disease where, and I think Elio's had a wonderful description of trying to figure out where syphilis originated and who was responsible for it. There is wonderful epidemiology where you can literally trace, and it always originates in the Far East, the resistance of gonorrhea as it moves, eastward and then into the various other parts of the world. It's just ever present for us, and this we do have to follow the recommendations of the local health departments on how we treat it. But it's still out there. It's gonorrhea and chlamydia, and most people will have both. It's interesting that these two just travel hand in hand, and it's the same behavior that gets you one gets you the other. So it's not surprising that people would have both of these infections going on simultaneously.
And how would you diagnose that?
These are going to present symptomatically in males. It's usually with a urethral discharge. Okay. And males are very, very interesting in terms that you will get males, if they don't have symptoms, are very rarely asymptomatic carriers. So that you almost always have a urethritis. So they'll come in, they'll have a discharge or a drip or various other, euphemisms for it that have been developed over the years that they will describe. It's always interesting when these people, when they walk into the emergency department, they're met by what's called a greeter, which is this nice little old lady who says, "What's wrong with you, dearie?" And then they try and get you back to into the treatment area as quickly as possible. And when we're doing things well, we'll get you back within 15 minutes. There's some places where you're going to wait 6 hours. We're pretty aggressive at getting you back there, so you're going to get back there pretty quickly. So you'll see something like they'll sign up with a complaint like headache, and they get put in an area that's kind of public, where because the headaches. We get you back there, but you're not getting your own room. You're kind of in a hallway or something along those lines. So the happy, cheerful physician's assistant will go back there and she'll say, "Oh, tell me about your headache," and they'll get this mumbled response like, "It's really not my head. And is there a male guy around I can talk to?"
Of course.
Yeah, okay, buddy, come here. So these PAs and female doctors are very adept at torturing these individuals. No, there's no guy here today. So tell me, what's your problem?
That's great.
Yeah. Now
Al, do you know the origin of the word for gonorrhea? Why it was called the clap?
Actually, I don't.
It's from the old French word clapor, which refers to a sexual sore and dates back as far as 1587.
Oh, hey, so this has been around for quite a while.
Oh, yeah. And then there's another suggestion that the word actually refers to a traditional treatment used to clear the blockage in the urethra from the gonorrheal pus. And again, that's one of the hallmarks of men, is they frequently present with the painful urination as a consequence of the pus. And so the penis would then be clapped on both sides simultaneously, I guess, to bust up that abscess as it's beginning to form with the pus.
I like that one.
Yeah, that might change the behavior a little bit. If we went back to that, we might have less cases going around.
Well, I know you talk about those PAs trying to torture poor souls, so maybe they'll print up cards.
Those are just treated then based on the symptoms, is that right?
You treat them both for chlamydia and gonorrhea. Right now, we are still, at least in our area, we can still treat the gonorrhea with the cephalosporin. So we will still treat them with Ceftin. Is the one that we use most commonly, and that's an oral. They can take 2 pills of that, and then we usually treat the chlamydia with azithromycin. So it's actually a gram of each, so they can take a bunch of pills and do better. Sometimes what we will do is, and we're particularly concerned, they'll get an intramuscular injection of ceftriaxone, which is actually still probably the best antibiotic out there for it. Now, what we're finding is for a while we were able to treat them with the quinolones, ciprofloxacin and levofloxacin and that class of drugs, but the organism very rapidly became resistant to that. And what we're seeing now is high resistance to that, not just for us, but for the pretty much across the country. So that's not bad. Now, what we are seeing is an increase in the gonorrhea that's resistant to the cephalosporins. And that creates a real problem because when you look at how do you treat these people, it becomes pretty difficult. Things have gotten narrowed down now. Spectinomycin and those types of drugs are still out there, but they're difficult to use. And so I think as this becomes more, resistance becomes more common, we're going to have to start to go into other medicines to treat them.
Hopefully we won't have to go back to the clap.
It might be more effective. It might be more effective. The females, on the other hand, can be asymptomatic for a long time. And they'll get what's called a cervicitis. And then just for whatever reason, all of a sudden the bacteria will ascend. And once it ascends into the uterus, they'll get an endometritis, which is very, very painful. And then it goes out the fallopian tubes and they'll get what's called a salpingitis. So the salpingeal area is infected. And there you get all kinds of problems because what happens with those people is the euphemism for that is pelvic inflammatory disease, which is really a bad euphemism. It's really an endometritis and a salpingitis. And the difficulty there becomes as these bacteria grow, you quickly evolve into a mixed flora and you get a lot of anaerobes up there. So you get the anaerobes and mycoplasma up into that infection. So you really have to treat these people with mixed antibiotics to be able to treat them. So now you're looking at treating them with something like the cephalosporin, but now you have to add on clindamycin or flagyl or one of those drugs to cover the anaerobes because they get these nasty anaerobic infections in there as well. So
then you run the risk of our good friend C. diff manifesting themselves if they happen to be a carrier of C. diff.
Yep, absolutely. So it gets uglier and uglier. And these people, and it's a shame because they'll scar down their fallopian tubes. They become sterile. It's just not, and a lot of them just going to get chronic pain. So it's not just an inconvenient infection for the females. It is a nasty infection. The males, the biggest problem that they'll get into is later on in life they'll get strictures in the urethra. And then they get urinary retention. They have to dilate the strictures and whatnot. So there, it's not as bad, but it's certainly for the females. It's just a really bad disease if left untreated. Ideally, what will happen is when we do their exams, we'll see the cervix inflamed, so we'll be able to treat them before they get any type of upper tract infection. Because once they get the upper tract infection, it causes all kinds of problems for them.
And since yesterday was World AIDS Day, you advocate the use of condoms to prevent the transmission of HIV, but condoms are also very effective in preventing the transmission of other STDs as well.
Yeah. Well, and the other thing is the epidemiology that goes along with it. So if you are diagnosed with an infection of that nature, we're also going to screen you for syphilis. So you're going to get blood work to look for. You'll get a VDRL. And we have a screener in our department who literally goes around and looks for people with high-risk behavior and will screen them for HIV. which is, and they just screen that with a saliva test. They basically, well, actually, no, they switched. They were doing saliva. They just switched to a blood test, which I don't know how they do it, but it's just one drop of blood, and they can run a test, and they'll let you know right then and there whether you're HIV positive. Now it's a screening test, so it's more sensitive than specific, and if it's positive, then we draw the blood from you to confirm it. But yeah, that behavior kind of gets you into a whole lot of trouble. We have not seen much in the way of syphilis. That at least every now and then we'll see somebody come in with a chancre, but it's usually the Haemophilus ducreyi chancre. It's usually not the syphilitic chancre. That's pretty much the top. Then once you get beyond the top 10, you get some oddball things that kind of fly in there. The different diverticulitis is actually fairly common. We see a lot of diverticulitis, which is an infection of the colon with outpockings there, and most of them are. It's interesting. It's a mixed flora, mostly anaerobic. And now what they're beginning to believe, we used to think it was just some inflammation because you have the colon, which is the large intestines. It's got all this trillions of bacteria in there, and then and the stool and whatnot. And the American diet being what it is, a lot of people are more constipated than they should be, and they get these outpouchings in the wall of the colon, which are the diverticuli, which then get infected, inflamed. And so we see a lot of that. That's actually fairly common. And we're seeing it in younger populations, which is interesting.
How do you treat that?
You treat them with antibiotics. Again, now what you're going to do is you're going to add 2 antibiotics, one that covers gram-negative rods and one that covers anaerobes. So typically you will go home on something like metronidazole, which will cover the anaerobes, and you'll go home on ciprofloxacin, which would cover the gram-negatives. Other antibiotics, Avelox is moxifloxacin, will cover both as well. So we see that. The other thing we see a lot of is cholecystitis, infected gallbladders. And this is fascinating. I think we have cornered the market on young people with cholecystitis. But, when I was in my training, they told you the people who got cholecystitis were females who were 40, who were a little bit overweight, those types of things. We see a lot of 20-year-olds, particularly postpartum, after they've delivered, who have cholecystitis in our population. And I don't know why. I don't think anybody.
It's not because of Philly cheesesteaks, is it?
Yeah. But here's the interesting thing. If you eat a lot of fat early on, your gallbladder is constantly emptying, so you don't get them.
That's true.
It's when they switch to the somebody decides to go on a diet and they cut the fat out. My brother did that. My wacko brother decided he was going to lose weight, so he cut all the fat out of his diet, and he did. He lost like 30 pounds. He looked great, and then he got gallstones and needed to get his gallbladder out. So, but yeah, it's if you let the bile just sit in there, they will get the gallstones, and then they just overwhelmingly get infected. And the other thing we see a fair amount of is gangrene, because we're a transplant center, so we have a lot of diabetics who have kidney problems, and a lot of diabetics just get a lot of vascular disease. And you get the end organs, their feet just get these horrendous infections, and they get gangrene, fairly frequently. So we see a lot of that. I mean, it's pretty much you can give them the antibiotics, but more times than not, it becomes an exercise in whittling where they just slowly take off, a couple toes, and then a year or two later, a couple more toes and part of the foot, and then they just kind of slowly work their way up there. It's just not a nice disease at all.
And it's principally a circulation issue as opposed to a microbial issue. Correct.
Although they do get ugly osteomyelitis, where the osteomyelitis being an infection in the bone itself.
Oh yeah.
And those are just a bugger to try and treat with them. And it's interesting enough, since a lot of them are anaerobes, the way they treat them aggressively now that we have a whole wound management team is they put them in hyperbaric oxygen chambers.
The poor anaerobes, they just can't deal with molecular oxygen. It just kills them dead really quickly.
Yeah.
If you can drive the oxygen in there, it's half the battle, and it's the alternative to circulation. But it requires the patient to take some effort to come down to the hyperbaric chamber and to undergo the time of sitting in there in the presence of increased atmospheric concentrations of oxygen to effectively trim the bacterial load down before it gets out of hand.
Right. It's actually kind of neat. The chambers are kind of neat, but I don't ever want to be in one. You get claustrophobic in those things. That's not some place you want to hang out. Although I think Michael Jackson had one in his house, which goes to show you it probably didn't work on. He didn't die of an anaerobic infection, so I guess it worked.
Yeah. Wonderful.
Yeah.
That's great.
But those are the main things that we would see, and then we wind up actively treating anyway. So, and there's lots of variations of them. But look, all of microbiology is fascinating. You see somebody with a fever. It can be, first of all, can be autoimmune in and of itself. But then there's just literally thousands of etiologies to it, and now it becomes down to if we can get it down to an organ system or either the respiratory tract or something along those lines, then you guys have already given us the background of these are the organisms that you might find there. If it's the respiratory tract and it looks like this, you're probably looking at picornoviruses. If it's the respiratory tract and it looks like this, you may have a sinusitis or you may have a bacterial infection in the throat type of thing. And once we can narrow those things down, it becomes much, much easier. So if we can get it down to a specific organ system, you guys have given us the answer for the most part.
That's only if you paid attention in micro. A lot of your younger colleagues who are going through the microbiology refer to us as bugs and drugs, and they just remember the drugs, not necessarily the bugs. Yeah. And I think one of the most important things I hear from the attending physicians is what you just said. You really got to know where the microbes hide. You have to know where staph is. You have to know where Neisseria is, because that is really what gives you that clinical intuition that you need. So anytime you see a med student or a resident, really pimp them to figure out who's there, because I think that's off. And that's what I tell the sophomore medical students. I point out to them, you really got to remember where, not so much which drug, because the drugs are constantly changing as the bugs adapt to the empiric treatment and they become resistant. But it's that place, because that place can actually give you that empiric head start on helping your patients get better. Whether or not they listen to me, I don't find out until they're actually attendings.
Yeah, and then you wind up with a couple of resistant organisms in the hospital because they've given 5 different things. This whole issue came down, really clearly. But the other day, I was a good friend of ours got admitted to the hospital, had diverticulitis, and she was getting chemotherapy for breast cancer. So she had no white blood cells in addition to a bacterial infection, and it really comes down to the fact that, okay, she's got this infection in a closed space that we can't get to the culture. Nobody's going to get to it to culture. Obviously, she quickly moved out of the emergency department and she was up in the intensive care unit. But so you don't have an organism to look at. You don't have a sensitivity to look at. So now you're falling back on what have the microbiologists told us the organisms are likely to be. So now we've got to attack them. We don't have any white blood cells, so we've got to pick antibiotics that can kill the bacteria, not just slow down their growth, because there's bactericidal and bacteriostatic antibiotics. So you really have to get that down correctly. And you've got to maintain meticulous, safety precautions in terms of the person's in isolation now because their white blood cell count's 0.4, so that they don't have any bacteria, so you don't give them another infection on top of it. So now you've got all the infection control people who taught you how do you keep somebody in a sterile environment until you can get this cleaned up. And it was just fascinating to watch, microbiology in action, how you took all this information, applied it to this patient under these special circumstances, and were able to get them through this. As it turned out, that they were able to keep the diverticulitis localized. It did perforate. They went in and did surgery, which is even more risky. But the person did absolutely spectacular when you applied all those microbiological principles. So it was actually very nice to watch it work in action.
But that was because of teamwork, where you had the infectious disease consult come in and say, okay, this is what we got to do to help this patient weather this horrific storm.
Right. But you had, I agree with you, but you had, in addition to infectious disease, you had the surgeons, you had the intensivist, you had the hematologist trying to figure out how to get some white blood cells back into this person, to give them the shots to get their bone marrow to start working. And then you had the lab that was able to say, okay, look, this is what the last, dozen or so diverticular abscesses that we had. This is what the bacteria look like. Let's go after these. This is what it's most likely to be. And then obviously once they got in there, to actually culture it and go from there. And you knew enough to say, okay, you got to treat anaerobes. There's a lot of anaerobes in here. You got to treat for the gram-negative rods. There's a lot of gram-negative rods in there as well. So you really saw microbiology come together there and get this person through.
Yeah, Bacteroides is the largest population of microbes below the diaphragm. Most people would think it would be good old E. coli, but it's B. frag. Bacteroides fragilis is the predominant organism below the diaphragm, and it doesn't have very much LPS, but it's a God-fearing gram-negative, and it's got a good beta-lactamase, and so one of the great cidal antibiotics. Hopefully, her Bacteroides was sensitive to penicillin, so you could actually use a nice cidal drug that has very little side effects.
Yeah, because you're absolutely right. Because now the next thing is you start, as you knock off the anaerobes is when Clostridia goes nuts.
Oh,
and that's so your normal drugs are clindamycin and those types of drugs, which treats Bacteroides wonderfully. But then you wind up with C. difficile, and the C. difficile has, and we can do this another time, but the C. difficile has just turned very aggressive. In the past, it used to give you diarrhea, and it was like, oh, it's a pain in the butt. But now it's become very, very aggressive, where it just goes right through the colon, and these people are getting colectomies, getting their colons removed.
Yeah, we have to do a C. diff episode at some point. We haven't done that yet.
Yeah.
I have one more question for you, Al.
Sure.
Just out of curiosity, what's the flu season like this year in the ER?
Mild.
Yeah.
Really, really, really mild. We have not seen, let's put it this way, we have not had, we've had a couple people with flu-like illnesses, but have not seen anybody who, any of the kids with the RSV, if we were admitting them, we also cultured them for flu. None of them have turned out to have flu. Mm-hmm. And we've not seen, and knock wood, it's been a very, very mild season. And I think, I'll give you my opinion on that. I think what happened is, when the H1N1 came through, we had just a nasty year, and then it went away, and then it came back. We had nasty again, and I think what happened is either the population all decided to get vaccinated, or they all got infected, and it hasn't antigenically shifted enough to cause a problem yet.
I think you're absolutely right. I think that's the trend that we're seeing, and it really drives home the fact that vaccines are good. Because a lot of folks during the H1N1 scare of 2009 did indeed get vaccinated, and those that didn't get vaccinated became ill, and because it was a very infectious agent, but didn't have very much disease associated with it. Mm-hmm. And so I think we have substantial herd immunity running around the country right now.
Yeah, I agree with you. I think immunization has helped a lot. And so people are always saying, why do I need to get flu vaccine? But it really does help, and it helps other people as well besides yourself. The more of us that are immunized, the less circulation we get. Yep. So that's been my impression too. I've been looking at CDC, and it looks pretty mild so far.
Yeah, I mean,
this year.
I think the only thing that would upset the apple cart is if all of a sudden there's a big shift and it comes, and we get a different one coming through. But I think the other thing with the flu is I tried to push this through this year and got a little bit too much resistance. But I at least within my department, it's mandatory. You have to have the flu vaccine or you can't work. Because
that's what it is here at the medical university. Everyone who sees patients must be vaccinated, or they get to wear a mask for their entire shift.
Yeah, and I think unfortunately the hospital said, well, we can't force everybody. In which case, the infectious disease people are going, what the hell? Grow some guts and make these people do it. But it's a mild season, so I think they're getting by. But we said, look. You mandated for all the people in the obstetrics floor because the H1N1, for whatever reason, is particularly nasty in pregnant people. And we've had a couple who were very, very sick with it. And in the ER, who the heck knows if you're pregnant or not? And so we said, you guys all have to get it. And we're at about almost 90+%. And the one thing we found that was fascinating is when you talk to the nurses, all of them said, or the docs and everybody said, absolutely, I think it's a wonderful idea. And if you said to them, okay, on Tuesday at 4 o'clock, we're going to vaccinate everybody. And on Friday at 1 in the afternoon, we're going to vaccinate everybody. Nobody showed up. But if you went to the department 3 times a day, when somebody from infection control or the nursing supervisor came down with a little basket full of syringes, everybody lined up and got their vaccines. So it wasn't I object to it. It was a matter of just make it a little bit more convenient for them, and everybody got vaccinated.
I think that's the key. You just have to make medicine convenient, and people will do it.
Hey, you walk into a CVS and they have signs $12.95 for a flu vaccine. I mean, I think it's good. It encourages people. They say, "Oh, I'm here. Let me do it."
Yep. Yeah. I got my shampoo. I got my my toothpaste. I might as well get my vaccine.
Yeah. So it's a commodity. The flu vaccine is the only one that's now a commodity, right?
Yeah. No, actually, you know what I saw? I saw this the other day, and I thought, son of a gun, I got to do this. They're now giving the varicella vaccine for adults. Yes.
Yeah, the shingles vaccine. Yeah.
Yeah.
Yeah, that's another one. Yeah.
And you don't want shingles.
No, you don't want to get shingles. It's painful. I've had it.
Oh, really? Ugh.
I mean, I kind of liked it because it's a viral experience, but and I could talk about it on the podcast, but I don't want to get it again. Yeah. But that's great. Thanks so much for doing that, Al.
Oh, my pleasure, guys. Really cool. I love talking with you folks.
That's great. I have to read two emails before we wrap it up here. Sure. First one is from Jim, who writes, "I'm greatly concerned about the harmful effects of nanotechnology. I'm old, but I have grandkids who already have to live with all kinds of junk in the environment. I guess it's a topic that fits in the virology category too, since are not nano-sized particles in the virus category. The scope of nanotechnology is so great that it looks like a wave of change, just like plastics. So perhaps it has to become an obvious and terrible hazard like DDT or an epidemic before better controls will be considered. Just thought I'd ask what your take is on the topic." So he sends us links to 3 articles about nanotechnology. We actually talked about this way back on TWiM 5. I don't know if you remember that, Michael. There was a study that we talked about where they looked at the effect of nanoparticles in an Arctic microbiome. And they cause problems. They do alter microbial flora, in particular nitrogen-fixing bacteria were affected. So what's your take on this, Michael?
I think that we don't yet understand the consequences of small size in something that is already pretty small. And by virtue of the fact that the genetic evidence, and you can go back and check out TWiM 5, it really showed us that we had different sorts of expression. And if it's happening in the bacteria, remember, we're mostly bacteria ourselves as people. Yeah. And, it could have consequences. And just like Al was talking earlier about, the children are cycling through viruses as they begin to develop their own biological personality, if you will. We really don't yet understand the importance of that biological personality, and when we introduce a foreign body like a nanoparticle, we yet don't have a handle on those consequences. So while they may be technologically neat, it could be Pandora's box. Yeah. So, he could be right, and I think it warrants further study, and Jim is maybe perceptive that it could be harmful. I know the United States EPA is seriously looking at nanotechnology and the presence of nanoparticles in the environment. So I think that's a very important topic that I think warrants further study, and we really need to begin to think about what it's doing to viruses, bacteria, fungi, as well as parasites.
Yeah.
Who knows, Al? One day maybe it'll be a new disease category, people coming in the ER with nanoparticle intoxication.
I guarantee you that at some point there is going to be a spectrum of diseases caused by it. Whether they're real or not, they will exist.
Yeah. Next one is from Richard, who writes, "I have a theory as to why mitochondria would be involved in programmed cell death." This comes out of our last episode where we talked about a toxin from H. pylori that interacts with mitochondria and induces apoptosis. He says it makes sense that if they are descended from parasitic bacteria, that mitochondria would have had the ability to kill cells. They may well have needed this in order to spread from cell to cell. It makes sense that evolution would adopt something already present in order to kill cells rather than inventing something new. I have no proof, but it does seem reasonable. Thanks as always for your interesting group of podcasts.
Mitochondria are fascinating, yeah.
He puts out a very interesting hypothesis that, you can design an experiment around to begin to test. Because our good friend, Rita Colwell has a nice organism called Vibrio that lives inside cells, copepods, and you can probably do that sort of experiment to see what's going on with the copepods and apoptosis and all those other wonderful things that folks now have assays, because the cancer world has taught us a lot about apoptotic events in eukaryotic cells.
Yeah, I'm just amazed that Elio had said that the closest DNA to mitochondrial DNA is Rickettsia, which is just a nasty, nasty organism.
You see that in the ER?
Yeah, actually, it's funny. We just had the wife of one of our docs just came in with Rocky Mountain spotted fever.
Wow.
Was she out hiking in the woods and had a tick bite?
No, I don't know where she got it. We usually see 1 or 2 cases a year. But yeah, she wasn't. I don't know where she got it, but she had all the classic symptoms of it. It was, and we did the biofelix test and whatnot. Everything came back positive on her. But she looked absolutely healthy, and she got treated with vibromycin and did well.
Yeah, this is a symbiosis that happened many, many years ago. So
yeah.
It's a good question. I always wonder why mitochondria are involved in cell death. That's a good idea, Richard. So we'll ponder that. So thanks, Richard, and thanks, Jim, for your emails. There are many ways you can listen to TWiM. You can find us at iTunes, at the Zune Marketplace, or, of course, at microbeworld.org. Microbeworld also makes an app that you can use to stream the episodes to your iPhone or Android device. You can find that at microbeworld.org/app. And you can always play episodes over there at microbeworld.org/TWiM. We do have a survey we'd love you to fill out to help us understand about our listenership. You can find that at triplemojo.com/TWiV. As always, send us your questions and comments to twim@twiv.tv. Al Sacchetti, thank you so much for joining us. It's great.
Absolutely my pleasure. I love talking to you guys.
Al's at the ER at the Our Lady of Lourdes Medical Center in Camden, New Jersey. And we'll have you back again.
Thank you.
For sure.
I'd love to.
Love to hear.
Thanks, Al. You've given me new material for my E. coli lecture on UTIs. I didn't know the one about the Caucasian, so
there you go.
That's great information.
Yeah, give my regards to your ER buddy down there too.
I will. I have lots of friends in the ER. They're a wonderful set of folks, and because you guys see bacteria all the time, they actually like to talk to me.
Wonderful.
Thank you, Michael Schmidt. Thanks for joining us.
It's been a pleasure, Vincent. This was a especially entertaining one.
Yeah, I love it. It's great to have Al on. Michael, of course, is at the Medical University of South Carolina. I'm Vincent Racaniello. You can find me at virology.ws. I'd like to thank our friends at the American Society for Microbiology for helping get TWiM along. Communications Director Barbara Hyde, Chris Kondayan, and Ray Ortega. Many thanks to you. Thanks for listening, everyone. We'll see you next time on This Week in Microbiology.